Good morning. Welcome to the Center for Cardiovascular Regeneration at Houston Methodist Hospital in the Texas Medical Center. I'm John Cooke, the chair of the department, and today we're going to be talking about a forgotten circulation, the lymphatic circulation. I'm going to be talking about current concepts on lymphatic disease and therapies for lymphatic diseases. And then we're going to have a talk from Dr. Jun-Dae Kim, who is one of our senior scientists working on the lymphatics. He's done some really interesting work on lymphatic endothelial cells and their migration and the role of those cells in the development of the lymphatics. So let me start with this first slide that illustrates the ubiquity of the lymphatic circulation. The lymphatics are throughout the body in all tissues. They start out as blind-ended capillaries that are entirely composed of endothelial cells. So those blind-ended tubes are there to collect fluid and protein that has escaped from the rest of the circulation. So they collect the fluid in the tissue. By the way, we lose about 2 to 4 liters of fluid in our tissues every day. So that's half a gallon to a gallon of fluid we lose every day in our tissues. And 100 grams of protein leak out through the capillaries, through the arterial and venous capillaries. So the lymphatics are there to collect that fluid and that protein. There's other reasons for the lymphatics. The lymphatics are also a defense against pathogens. So pathogens get picked up by the lymphatics and they get transported where? To the lymph nodes, where the body can start to mount a response to that pathogen. There's actually a road also for the immune cells. Immune cells can travel throughout the lymphatics and do immune surveillance through the tissues as they're passing through the lymphatics. Anyway, these capillaries merge to form larger tubes that ultimately travel alongside veins in the large veins in the tissues. They merge at the lymph nodes and then they empty into the thoracic duct. The thoracic duct is right here. Whoops, sorry about that. Let me go back. The thoracic duct is in the chest, obviously, and empties into the left subclavian vein. So all of that fluid and protein that the lymphatics have collected ultimately end up in the thoracic duct and it empties into the left subclavian vein. So that fluid and protein gets returned back to the circulation. What you're seeing here are some beautiful diagrams that were, I think they're the best anatomic depiction of the lymphatics that we have. These were done 100 years ago by Sappi, a French anatomist, who used mercury injections to delineate the lymphatics. And here you can see how ubiquitous the lymphatics are and how they merge to form larger vessels. Those vessels actually have vascular smooth muscle that is vasoactive, that can contract. So one of the forces that are propelling the fluid through the lymphatics and into the thoracic duct are the contractions of the popliteal, of the lymphatics. At the popliteal lymphatic, there's been studies showing that if you ligate that experimentally in sheep, that the lymphatics can generate pressures of up to 50 millimeters of mercury. So they can generate quite a bit of force. The other way the lymphatics fluid is moved to the thoracic duct and into the circulation is by muscular contraction. In the abdomen, it's through movement of the intestines. The gastrointestinal peristalsis also moves the lymphatics toward the thoracic duct. And in the thoracic area, the negative pressure generated by inspiration will drag fluid up into the thoracic duct and into the left subclavian vein. These beautiful anatomic delineations of Sappi were made possible by Anton Nook, who used mercury injections to outline the lymphatics. That was the first person that did that. In the chest, in the trunk, lymphatic capillaries also similarly will merge with larger, to form larger vessels. In the arm, they merge into the axillary nodes. That's important to know this kind of anatomic distribution of the lymphatics, because the nodes, the axillary nodes and the inguinal nodes, are areas where all the lymphatics from that limb are merging. And if you have damage to those areas, that can cause lymphatic obstruction for the whole limb, right? Does anyone know who discovered the lymphatics? Actually, they're discovered quite a long time after de motu cordis, after Harvey's description of the circulation of the veins and the arteries. The lymphatics were not known to Harvey. It was an Italian anatomist from Milan, GASPARO ASELLI'S, who discovered the lymphatics in 1622. And I love his description of his discovery. I'm going to read it to you. What's shown is a woodcut carving of the lymphatic circulation that he discovered in the intestines. So in the intestines, the lymphatic capillaries are running through the intestinal wall, and what are they picking up? Can anyone tell me? What are the lymphatic capillaries picking up? They're picking up fat. It's called chyle, C-H-Y-L-E. They're picking up fat from the intestine. That's their job. After a meal, they're picking up the fat, and you can actually see them because the fat has a whitish color, right? So ASELLI'S describes his discovery. He was trying to demonstrate to his students the innervation of the diaphragm. So the diaphragm is innervated. It's a muscle that contracts, right? So he was trying to demonstrate the innervation. And while he was pulling down the intestines for that purpose, he says, "I suddenly beheld a great number of cords, exceedingly thin and beautifully white, scattered over the whole of the mesentery and the intestine. Wherefore, struck by the novelty of the thing, I stood for some time silent. When I gathered my wits together for the sake of the experiment, having laid hold of a very sharp scalpel, I pricked one of these cords, and indeed one of the largest of them. I had hardly touched it when I saw a white liquid like milk or cream forthwith gush out. Seeing this, I could hardly restrain my delight." You know, so this is what we feel, right? When we're in the lab and you see something you've never seen before. And you know, you all have had this experience, or will have this experience working in this center to find something that no one's ever seen before. And that's so exciting. So I love this description of his discovery. Now the funny thing is that when he went to demonstrate this at a scientific meeting, you know, everyone's gathered around the auditorium, you know, the amphitheater, all the scientists are there, the physicians, to see the demonstration of this new circulation that ASELLI'S claims to have found. And he opens up the animal, the dog, and he, you know, opens up the intestines, you know, displays the mesentery, and there's nothing there. There's nothing there. You can't see the lymphatics because the animal hadn't eaten. So that was embarrassing. But later on, he began to understand the relationship between feeding and the ability to see the mesenterics. And so yeah, so he discovered the lymphatics. Now, I'm going to talk about lymphedema because Jun-Dae Kim's scientific work is relevant to this area. So when you have an obstruction of the lymphatics, all of that fluid and protein that is supposed to be gathered up by the lymphatics and returned to the circulation fails. That fails. So fluid accumulates. There are several forms of lymphedema. There's primary lymphedema, which is due to mutations, congenital lymphedema, that can occur in babies. Also, there's lymphedema tarda, which occurs not in the baby, but later on in adolescence. And then there's, I'm sorry, that's lymphedema precox. Lymphedema tarda is occurring even later in usually women around the age of 30, 35. So it can occur at different stages of life. You can have mutations that reduce the ability of your lymphatics to carry lymphatic fluid. So this is a child with congenital lymphedema, mutations in FOXC2, for example, a transcriptional factor, and VEGF receptor 3, that's the receptor for VEGF-C, which is the major growth factor for the lymphatics, right, Jun-Dae? And those mutations can cause congenital lymphedema. Then lymphedema can be secondary. It can be secondary to surgery. So when women have, in this country, post-mastectomy lymphedema is probably one of the major causes of lymphedema. When women have the lymph nodes removed in their axillary axillary nodes, they have the nodes removed, they can develop lymphedema. The nodes are removed because they may be carrying cancer. That's another thing that lymphatics do. They can be a route for metastasis. So in women with breast cancer, the breast is removed, and often the axillary nodes are removed, and the woman is left then with post-mastectomy lymphedema. But the greatest cause in the world of lymphedema is what? Anyone know?
Filariasis?
Filariasis, right. It's an organism. I believe Wucheria bancrofti is the name of the organism, but it's a filarial organism. You can see it here in this lymph node within the lymphatics. It gets into the skin through breaks in the skin and then travels through the lymphatics and ends up in the lymphatic node, and they multiply and they can block the lymphatics. So that's filarial lymphedema, a major cause of lymphedema in the world. Now, most of the time, the diagnosis of lymphedema can just be made clinically, okay? Swollen limb. You can differentiate it from other causes of swollen limb. I won't go into the diagnostic signs, things like Stemmer's sign, which Roman's probably familiar with, but there's ways to differentiate a lymphedema due to venous disease, lymphedema due to lymphatic disease, or heart failure, other causes. I won't go into those clinical details, but sometimes we use imaging tools to help us, and this is one. You can do MR imaging, and what you can do is you can place some gadolinium if it's a limb, a lower extremity with lymphedema, you can put some gadolinium into the foot, dorsum of the foot, and the lymphatics will take that up, and the lymphatics will transport it. And you can follow the transport of the gadolinium through the lymphatics, and normally it's pretty fast. Within minutes you start to see the gadolinium traveling through the lymphatics, and you can see the outline of the lymphatics, and it disappears pretty quickly. But in someone with lymphedema, the transport is slow, and also it may be blocked, and it may accumulate. In this case, the lymphatics of this woman, she has a lymphedema due to pelvic node dissection. So she had removal of a cervical cancer, and she had a lot of nodes removed in her pelvis, and she developed lymphedema as a result. And she has some dilated lymphatics. Above this level you can't see, but the flow was stopped. So, and you get this dermal backflow, you get these collections of gadolinium in the skin, which are characteristic of a lymphatic obstruction. This woman has primary lymphedema, congenital lymphedema of an unusual sort. Most primary lymphedema is due to hypoplasia or aplasia of the lymphatics, meaning they don't develop. But in a few cases, there's this megalymphatics, tortuous, large megalymphatics. They're not functioning very well. It may have something to do, it may be like tortuous veins, large veins that aren't functioning well because the valves can't coapt. So the valves can't coapt, then the lymphatic flow is not unidirectional, it just kind of sits in the lower extremity. So that may be the cause of lymphedema in people with tortuous megalymphatics. Now, what's the treatment for this? Actually, I started a lymphedema clinic at Stanford when I was there, and I was assisted by my colleagues Sanjay Shuba and Stan Roxon. And we mainly saw women with post-mastectomy lymphedema. We had a big cancer center at Stanford. A lot of women developed post-mastectomy lymphedema. And what we did, and what still is the current approach for lymphedema, is massage. It's called decongestive physiotherapy plus tight bandaging. And in this study, we saw people, mainly women, that had had lymphedema on average for about 4 years, and pretty much untreated, not properly treated. And what we did is put them through our clinic, and then we followed them up a few months later on an outpatient basis, because we teach them how to do the bandaging and the massage. And what you can see is that we reduce the amount of edema in the arm by about 40–50%, and and this is the leg, I'm sorry, and this is the arm in people that had arm lymphedema with this approach. And in follow-up, so black is our initial result. We then, in the first week of treatment, and we send them home, and they have their relatives, and they do the therapy at home. And the therapy could be maintained, which was important to show that it could be something that could be done at home. But we need better approaches. So today you're going to hear from Jun-Dae Kim about some new basic science insights that may be useful for treatment of lymphedema. And I want to mention one of the new approaches actually being tested now in the clinic. It was work that came out of my lab in part at Stanford in collaboration with a company called Fiberline, which is pursuing the development of a lymphatic device. They came to me with these nanopatterned matrices, and we're thinking of making conduits for arterial obstructions. And I said, well, you've already got these, you've made these threads. They make this nanopatterned collagen matrix. They spin it into threads. And I said, why, instead of trying to spin the threads into a large conduit, why don't you use the threads for lymphedema? And so they liked that idea. And what these threads are, basically, this nanopatterned collagen matrix is wrapped tightly to form these threads. And here's another view of those threads, a cross-sectional view. They have a lot of internal structure, but the cells are growing on the outside. And as I'll show you, endothelial cells actually love this matrix. And it may have something to do with the fact that these internal, this internal structure may provide for accumulation of proteins, growth factors, that kind of thing. But they're also sensitive to the patterning itself, the endothelial cells. So we wanted to see how endothelial cells would survive on these matrices. And we found that endothelial cells aligned with the axis of the nanofibers. Their function was improved when they were grown on nanopatterned collagen as opposed to collagen that was not nanopatterned. And their survival was improved when we implanted them in vivo. So this is just some pictures. It's interesting. I mean, these endothelial cells can't sense fibrils that are 100 nanometers, but they can sense fibrils when the matrix is made of fibrils that are 30 nanometers. They can sense the alignment of those fibrils. So it's very interesting that the endothelial cells are sensitive not only to the alignment, but also to the diameter of the fibrils. So you can see the endothelial cells line up, and this is some quantification of that. 45 degrees would be just random, and then 0 would be perfectly aligned. 90 degrees would be perfectly at an orthogonal axis. But so after the FD30, rather, this is the fibrils that are 30 nanometers, they're aligned pretty well. And they look different too. You can see they're more linear when they're lined up on this collagen matrix, similar to the way they look in a blood vessel, right? In a blood vessel, a healthy blood vessel, the endothelial cells don't look like this, they look like this. They're aligned with the flow. And just some nice pictures, scanning EM showing endothelial cells growing happily on these nanofibrillar collagen and expressing all the right markers, CD31, et cetera. The other thing is we did some testing of function, and their functions were improved by comparison to just control collagen matrix. For example, we looked at the ability of the endothelial cells to ward off monocytes. So you don't want monocytes, you don't want inflammation, you don't want monocytes sticking to the endothelium. So when they were aligned on the nanopattern collagen, they were more resistant to monocyte adhesion. They expressed less ICAM, an adhesion molecule, and they expressed less MCP1, a chemokine that attracts monocytes, monocyte chemokine fat protein. And then we did some studies where we transfected them with luciferase so that we could study them in vivo. And this is just the pictures of the fibers after we had transfected them with GFP luciferase construct. We put them into animals. By luciferase bioluminescence, we could show that the cells survived much better when they were grown on the graft, implanted on the they're grown on the graft, and then the graft was implanted in the animal, as opposed to just putting the cells in by themselves. They survived much better in these immunodeficient animals. These are human lymphatic endothelial cells growing on a fiber in immunodeficient animals. So anyway, we did a lot of other work to characterize them before we did lymphedema study. We did a pig lymphedema study, and this is just a early study to see if these are safe. This is a safe approach. So basically in this pig model of lymphedema, the nanofibrillar collagen scaffold was tested. The endpoints were lymphatic density and fluid accumulation, and there was some evidence that the fibers could improve lymphatic drainage in this pig model. The way the pig model was created was the lymphatic nodes were removed from the hind limb of the animal, and then the animal was irradiated, much like women are, the lymph node is removed from the axillary node and they get radiation. So the animals, over a period of 3 months, developed lymphedema, and then the scaffold was implanted. And the scaffold, in this case, it's called a BioBridge, was implanted with lymph node or not. This is an autologous lymph node that's removed from another part of the animal. And the reason for that is that it generates VEGF-C. Okay, so, and that is and then the untreated animals, and then a BioBridge with VEGF-C. VEGF-C is the major growth factor for lymphatics, but in this case, the VEGF-C was implanted, was absorbed throughout the BioBridge. In any event, we saw that the BioBridge improved lymphatic vessels in the area of the implantation. We did immunofluorescence, and we looked for vessels that had both live-1, which is a lymphatic protein, and alpha smooth muscle actin, which is a vascular smooth muscle protein, as opposed to those that were live-1 negative and alpha smooth muscle positive. Those are blood vessels. So we just counted blood vessels, and we found that the BioBridge, whether it was implanted with the lymph node or with a VEGF-C, improved lymphatic density. And when we looked at the fluid in the limb, the fluid was reduced in those animals that got the BioBridge plus the lymph node transfer. The untreated control didn't change much. This was curious. We don't understand this, but it might be due to the fact that when we absorbed VEGF onto the BioBridge, that there was no gradient. With the lymph node, there was a gradient. The lymph node is making a lot of VEGF-C, and there's no VEGF-C down at the end of the BioBridge. Maybe that has something to do with the need for a gradient. In any event, I'm going to stop here. This is early work. The BioBridge is just beginning to undergo trials in Europe right now in women with lymphedema. But this is just some of the early work I wanted to show you in advance of Jun-Dae Kim's work to study, which studies lymphatic migration and lymphangiogenesis. So thanks very much.
Thanks for the information and interesting talk. Now we come to the question and answer session and question.
Just remember to turn on your microphone.
Thank you, Dr. Cooke, for the great introduction and this one about this lymphedema. So I have two questions. Actually, one question is about this early study using mercury injection. First of all, if I understand correctly, mercury is very toxic, and how do the doctors do the imaging for the mercury injection?
Oh, that's a great question. I failed to tell you that these studies were done in cadavers. So it was just an anatomic study. Another thing that we use now, rather than mercury, is silver nitrate. That stains the lymphatic endothelial cells very well. Again, that's something we do in people. If we want to image the lymphatics in people, we can use lymphangiograms. So we can actually take iodinated contrast, that we use for contrast angiograms in the blood vessels. We can inject that into the dorsum of the foot and watch that taken up by the lymphatics. But that also irritates the lymphatics. So we tend not to do that anymore, particularly for patients with lymphedema, because the stuff dwells in the lymphatics even longer and can cause damage. So we use, instead, lymphoscintigrams. We use radio-labeled albumin. And just in that picture I showed you with the gadolinium and the MR images of the gadolinium uptake, you can see something similar with lymphoscintigram with radio-labeled albumin, but the spatial resolution is poor. You get much better spatial resolution with the MR imaging, but that's expensive. Most of the time it's unnecessary. Most of the time we can make the diagnosis just with clinical exam.
question about this. Last you have the
Nanopattern
yeah,
collagen.
nanopatterns. So how it actually was planted? Is that they plant the whole sheet of this matrix, or they were?
No, that's a good question. So the idea is that the surgeon will tunnel the. When you have the surgery, the lymph node removal and radiation, it creates a scar. So the reason people develop lymphedema is because that scarring just damages the lymphatic transport. And so now you got this big blockage to lymphatics. So in Europe, they've been doing some lymph node transplantations into the axilla, and that has some benefit. But the problem is the lymphatics still have to migrate through this scar. So our idea was, okay, put the axillary, they take vascularized lymph nodes from the groin and do micro dissection and microsurgery to hook up the vessels that supply the lymphatics with blood, the lymph node with blood. And then they have a living lymph node in the arm now, where the woman had none. And the lymph node secretes VEGF-C to enhance lymphangiogenosis. But what we're doing is we're putting some little conduits in so that the lymphatic endothelial cells can grow along those conduits up to the lymph node from the tissue that's obstructed. So that's the idea. You have a train station, but you need tracks. So we're just creating the tracks to get to the train station. All right, I think we should go on to Jun-Dae Kim's
I have
presentation.
one question, actually. I am not I am not MD, so I have a question about the therapeutic method. Usually MD use surgery, but so we want to develop the gene therapy or drug mediated therapies. And so I think what is best for current lymphedema patient?
Okay, so you're asking about models of lymphedema.
Yeah.
So there is a rat tail model where there's a circumferential removal of tissue at the base of the tail of the rat. That's one. There's a rabbit ear model where they do something similar at the base of the ear, remove tissue at the base of the ear. I think the best model is the pig model. That is a difficult model and it's expensive. So the first testing could be done in with the small animal models, and then you can move to large animal models. Okay. Thank you for that question.
Thank you for all wonderful question and answer. Before the next presentation, I'd like to introduce Dr. Jun-Dae Kim. Dr. Kim got his PhD degree from the Korea National University in Korea, and in 2010 he joined the Dr. Fang's lab, and in 2016 he focused on understanding the lymphatic vessel development in zebrafish and mouse, and is related signaling.
Yeah, turn your mic on.
It's on. Specifically under cholesterol metabolism and ERT5 signaling in dysregulated lymphaenogenesis. Today, he will present his work progress as titled PKG, ERK5, MM2 signaling, and the migration of the lymphatic endothelial cell. Now I will turn it over to Dr. Kim.
Yeah. Thank you for very good introductions. Yeah. Good morning, everyone. Yeah, I am Jun-Dae in Dr. Fang's lab. Yeah. I will talk about the current my working in progress about the PKG, ERK5, and MM2 signaling and migration of lymphatic endothelial cells. Here is a very brief introduction for zebrafish lymphatic vessel development. Around the around the 1.5 DFF stage, lymphatic endothelial cells suddenly appears in the cardinal veins. This is the green cell is the lymphatic endothelial cells in here. They result from ADC specific lymphatic endothelial cell specification and differentiation from existing venous endothelial cells. After that, they start to migrate out from venous to form mature lymphatic vessels. Actually, in the lymphatic endothelial cell development, there are several different processes. They need specification, differentiation, migration, and survival, as well as the tumor maturations. In this study, my major gene is ERK5. ERK5 is one of MAP kinase signaling mediator. Actually, there are several different types of MAP kinase mediators. Each of MAP kinase signaling cascade responds to growth factor or cytokine, G protein, as well as experimental stress. Also, each of MAP kinase signaling cascade have a different substrate for signaling cascade. Also, these individual MAP kinase signaling cascade have a different physiological response in the context-dependent manner in the various cell types. Actually, first we knew that phospho-ERK5 expressed in the GASPARO developing endothelial and lymphatic endothelial cells. So this figure is a coronal sectional image of this transgenic species stained with phospho-ERK5. Actually, in this figure, green is for endothelial cells, and red is for peroxone positive lymphatic endothelial cells. These two bright one is autofluorescence from blood cells. In this image, phospho-ERK5 expressed in the blood vessel and lymphatic endothelial cells here. As well as the as early as 32 HPF, rather than this ERK5 expressed in the lymphatic tube, here. First, we use the chemical inhibitor to test the ERK5 functions in the lymphatic vessel development. This XMD8 is a specific and potent ERK5 inhibitor. We treated this ERK5 inhibitor from 48 HPF until 4 DPF stage. This time is for lymphatic development in the GASPARO. And we imaged in the this region in the transgenic PC. In the here, green is for blood vessel and red is for lymphatic vessels. So, ERK5 inhibitor treatment affect the lymphatic vessel formations as a dose-dependent manner in the GASPARO embryo. In similar with the GASPARO embryo, this ERK5 inhibitor treatment also block the lymphatic vessel formations in the mouse diaphragms. Next, we reconfirm the ERK5 functions using morpholino-based ERK5 knockdowns. Actually, ERK5 morphant display the lymphedema phenotype at 6 DPF stage, and they have a lymphatic vessel defect at 4 DPF stage. However, we couldn't see any blood vessel or heart defect at 4 DPF stage. It suggests that ERK5 signaling is more specific in the lymphatic vessels than blood vessels. Last, we made ERK5 mutant using Cas9 CRISPR method. Actually, ERK5 knockout embryo have lymphedema, and they also have a lymphatic vessel defect. So, this is a lymphatic development step of lymphatic endothelial cells. They need to collect specification, differentiation, migration, survival, and maturation process to make complete lymphatic vessels in GASPARO mouse and humans. Again, lymphatic endothelial cells appears in the specified in the cardinal vein here, and then they are migrate out. So we think alcohol fiber can affect one over this process in vivo. So we have taken image of these regions in the these transgenic fishes. So and we made a map of LC localizations in the this development stage. This stage is for LC specification and starting to migrate out. First, there was no change in the total number of LCs. That means specification is normal in the alcohol fiber knockdown embryo. However, in the control embryo, most of lymphatic endothelial cells in here localized in the dorsal vein regions. A few cells in the middle of veins. This means they already start to migrate out from veins. This cell is just specified in the veins. However, in the alcohol fiber knockdown embryo, most of cells are middle of the veins. That means they just start in the after specifications. Just a little few cells start to migrate out here. So that means alcohol fiber can affect the ADC migrations, not ADC specification or differentiations. Here, we used the 3 different approaches to block the alcohol fiber activity in zebrafish embryo: chemical inhibition, morpholino-based alcohol fiber knockdown, and the mutant generations. Altogether, we found that alcohol fiber is essential for lymphatic vessel development. In our experiment, also, we found that PD5 inhibitor can upregulate alcohol fiber activity. Actually, PD5 is a very famous molecule in the cardiovascular system. Originally, PD5 was developed for cardiovascular applications. Actually, cyclic GMP is transited to GMP by PD5. That means PD5 is antagonist for PKG. So a PD5 inhibitor is agonist for PKG. In our in vitro cell experiment, we found that several PKG inhibitors can activate, can phosphorylate the alcohol fibers. So we tested the PD5 inhibitors functions in our alcohol fiber knockdown models. We just treated several PD5 inhibitor. Embryo don't have any defect. Otherwise, when we treated PD5 inhibitor with the alcohol fiber inhibitor, this lymphatic defect was partially rescued by PD5 inhibitor treatment. So we think PKG may have a role in the zebrafish lymphatic vessel development. So we tested the PKG functions using chemical inhibitor over PKG. This KT is a strong specific PKG inhibitor. PKG inhibitor treatment affect the lymphatic vessel formations as a dose-dependent manner. Also, we confirmed the PKG functions using morpholino-based PKG knockdowns. PKG morphant have a lymphaedema, and also they have a lymphatic vessel defect as a dose-dependent manner. Next, we tested the epistatic relationship of alcohol fiber and the PKG. First, we treated a very low dose of PKG inhibitor or alcohol fiber inhibitor. In this embryo, lymphatic vessel formation was normal. However, we combine these normal conditions, embryo has a severe lymphatic vessel defect, suggesting that PKG and ALK5 has epistatic relationships. So now we know that PD5 inhibitor unregulate ALK5 activity, and the PKG is essential for lymphatic vessel formations, and PKG and ALK5 have an epistatic role. So next, we try to find the ALK5 target genes in the lymphatic endothelial cells. So we treated the PKG inhibitor to human lymphatic endothelial cells, and we did endothelial cell targeted gene expressive profiling. So we found that MMP2 is significantly downregulated. So we think MMP2 is one of the functional ALK5 target genes in the ADC migrations. Yeah. This is a whole summary for my study. We think some GPCR can activate PKG, and ALK5 is a downstream signaling mediator for PKG molecules, and MMP2 is a functional ALK5 target gene for ADC migrations. I have a storyboard. Yeah, I did little many. I already got many results, but I need some in vitro cell experiment for ALK5, and also I have to start some experiment for MMP2 and lymphatic migrations. Actually, many data has come from my former lab in Yale Cardiovascular Research Center. In here, I will adding some result with Dr. Pang, and also this Career Development Award is supporting this project. Thank you for Dr. Cooke for mentorships for my grant. Thank you.
Thanks for the amazing talk. Any questions?
I do have one. That was actually really very strong science, really interesting. You showed us that ERK5 is required, the activity of ERK5 is required for lymphatic development, and it appears to play a role in lymphatic endothelial cell migration. Furthermore, you showed us that it's regulated by cyclic GMP, and phosphodiesterase inhibition could enhance the ERK5 activity and lymphatic development. So we have drugs that have that effect, that are cyclic GMP phosphodiesterase inhibitors. You've had some of them up on the screen. Sildenafil and other drugs can have the action. So is it time for us to start considering clinical studies with cyclic GMP phosphodiesterase inhibitors?
But there is a very good paper in the New England Journal of Medicine, published around 10 years ago. Actually, PD5 inhibitor can partially rescue the congenital lymphadenoma.
Oh, really?
So, but in that paper, there is no mechanisms. So we think actually. There is some genes already known about the congenital lymphedema, lymphedema, especially in the VEGF3 and the VEGF-C, other things. But there is still unknown factors for lymphedema, congenital lymphedema. So we think some congenital lymphedema might be related with ALK5 signaling. Also, that type of congenital lymphedema can be rescued by sildenafil or another PD5 inhibitor treatment. So I think so already PD5 is a very famous drug. It's a very safe drug for humans. Also, there is I think one or two papers already published about the PD5 inhibitor and congenital lymphedema. Yeah, so we think we just want to provide some scientific signaling mechanisms. People don't know why PD5 inhibitor can work for lymphedema.
Yeah. I think Colleen also has a question, but I just want to comment to follow up. With respect to animal models, I think you now want to follow up with some mammalian animal models, follow up these zebrafish studies, and you could use, there's the rat tail model, there's a rabbit ear model. These are models that you could potentially use your sildenafil in to see if it could improve lymphatic flow.
Yeah, so I think, actually I have some plan for mouse experiment. Mouse experiment very easy. Just we can inject PD5 inhibitor and the ERK5 together in the pregnant mothers, and then we can just we can see some lymphatic patterns in their embryo. Yeah, so it's very easy.
I wanted to ask, actually, and make sure that anyone else here in the back of the room has the opportunity to ask any questions they have. But Dr. Cooke presented on a wonderful methodology to help improve edema and stuff like this. I know it's very difficult to do surgery in a zebrafish. They're very, very small fish. But as you move into the larger animal models, are you currently planning to do any experiments incorporating any of these surgical treatments to see how much they benefit?
It is I think actually I am not MD. It is not matter about the PhD or MD. Actually, I want to suggest some method for drug or gene therapy, not just the surgery or just the massage. It's a problem. I think So it is just a concept. I think it is related with just the concept of study. Some just good doctor just want. I think it's the same with the cancers. Cancer, some people just said if we have a cancer tumor, we just can take out them. But some science try to remove or using some drugs or gene therapy. So I think we can do. I think if we can treat the ERK5 inhibitor in the field. If they have a lymphoedema, sure. So we can just try to implant some nano materials. But it looks, I think, it seems very easy. But some people it is difficult. So I think I am doing some little bit basic research, so not translation. Actually, I have to go translational research to get grant, but I think now is for just stage. I am in the stage for just a little bit basic science to develop, to find the new genes or new signaling cascade for lymphatic development or lymphatic physiology. So.
I think you have to couple your study with Dr. Lee's findings. So obviously Dr. Lee's lab has done some very nice work on this ERK5. So have you found any defects in angiogenesis? Because Dr. Lee's work also shows ERK5 is this.
So this concept is, I think, in the. So I think this timing is very important. Usually we treated ERK5 inhibitor and PD inhibitor from 2 defect stage in the zebrafish. That means at the 2 defect stage, already done for angiogenesis. Or most of vessels are already engaged in this stage. But lymphatic development start to in the T-cell period. So we just treated these chemic drugs to block the only lymphatic and the lymphatic development. It is very similar to tissue-specific knockout models in the mouse. So I'm sure ERK5 is actually in the knockout ERK5 mouse. They died from a cardiovascular defect very early.
Yeah, I think Dr. Fang's question is a really good one because you're basically what you're asking is this effect of ERK5, is this involvement of ERK5 in lymphangiogenesis, lymphatic development specific? And it's the answer probably is no. I mean, the timing here was important because, as you're pointing out, in development, you have you already have the arterial and venous development occurring, and then you have lymphatic development. So you timed it so that ERK5 had a greater effect. The ERK5 inhibitor had a greater effect on the lymphatics. But if we're talking about therapies, and just going back to this idea that we could use cyclic GMP phosphodiesterase inhibitors, let's say sildenafil, in the treatment of lymphedema. Yes, that might have beneficial effects on the lymphatics, but it's also going to have an effect on the arterial circulation. So what does this cyclic GMP phosphodiesterase inhibitor do to the vasculature, the arterial vasculature? Well, it dilates it. It improves blood flow. It increases blood flow, right? And that could actually make lymphedema worse. If you're increasing flow to the limb, causing vasodilation, that could increase the transudation of fluid into the limb. So, you know, you'd have to see, but I think it would be, based on your work and based on the clinical cases you talked about, the treatment of sildenafil of congenital lymphedema, I think it would be worthwhile to consider a trial. Maybe for you, though, you want to first see if your results can be replicated in mouse models or some mammalian model.
We come to our end part of the meeting. We would like to say thanks again to our two presenters.
Okay. Okay. Thanks, everybody. Again, just to remember, we have our vascular meeting coming up. Please submit abstracts. Please register for it. And look forward to seeing you guys there August 23rd, 24th. Okay. Thank you.